Hey guys, this is FixerMed. Welcome back to my high-yield hematology and oncology review series for the USMLE Step 1 NBME CBSE and NBME CAS examinations. In this series, I will be covering the entire system of hematology and oncology in a comprehensive but high-yield manner. This will be part 23 of my multi-part video series of doing so. Today we will be taking a look at Heme Synthesis Disorders. Without any further delay, let's go ahead and get started on today's content. Today, I'd like to open up the presentation by covering sideroblastic anemia and lead poisoning. Sideroblastic anemia, impaired first step of heme synthesis, succinyl-CoA plus glycine via B6 and D-alanine synthase to D-alanine due to deficiency or impairment of D-alanine synthase, can be X-linked recessive or caused by alcohol. Failure to incorporate iron into heme leads to ring sideroblasts, erythroblasts with iron-laden mitochondria forming a ring around a nucleus. Iron-laden macrophages stain blue with Prussian blue stain, a key image for USMLE. Lead poisoning. Lead inhibits D-alanine dehydratase and ferrochelatase, leading to a buildup of D-alanine. Classic vignette: 2-year-old eating paint chips in an old house with mental deterioration. Next, I'd like to take a look at acute intermittent porphyria AIP. Acute intermittent porphyria AIP, autosomal dominant disorder due to deficiency of porphobolinogen deaminase, leading to buildup of porphobolinogen and D-alanine. Classic symptoms: red/pink/port wine-colored urine and abdominal pain. Patients may have miscellaneous neurologic findings, but not always. Treatment: hemetin and glucose. Alright, moving on. Next, I'd like to take a look at Porphyria cutanea tarda PCT. Porphyria cutanea tarda PCT, caused by deficiency of uroporphyrinogen decarboxylase, leading to increased urinary uroporphyrins. Classic symptoms: photosensitivity and blistering. Urine can appear tea-colored or dark, different from the red/pink/port wine-colored urine seen in AIP. Important distinction for USMLE questions. Alright, moving on.
All right, guys, now that we have covered all of the content, let's go ahead and take a look at some questions to review the knowledge you have gained so far.
A 45-year-old man presents to the clinic with fatigue, pallor, and irritability. He has a history of chronic alcohol use and works as a painter. Laboratory tests reveal a microcytic anemia with a mean corpuscular volume MCV of 72 femtoliters. Peripheral blood smear shows ringed sideroblasts and basophilic stippling. Prussian blue staining of bone marrow cells reveals iron-laden macrophages. Which of the following is the most likely cause of his condition?
All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now.
The correct answer is D. Lead poisoning. Lead poisoning inhibits the enzymes D-alanine dehydratase and ferrochelatase, leading to the accumulation of D-alanine and causing microcytic anemia. This condition is often associated with basophilic stippling of RBCs and can present in adults with occupational exposure to lead, such as painters. The presence of ringed sideroblasts on the peripheral smear and iron-laden macrophages, seen with Prussian blue staining, further support the diagnosis.
All right, let's go ahead and see why the other answer choices are incorrect.
The incorrect choices can be explained as follows. A iron deficiency anemia typically presents with microcytic anemia but does not cause ringed sideroblasts or basophilic stippling, and iron-laden macrophages are not a characteristic finding. EB12 deficiency causes macrocytic anemia, MCV greater than 100 femtoliters with hypersegmented neutrophils and does not typically cause basophilic stippling or ringed sideroblasts. Chronic alcohol use can lead to sideroblastic anemia, but the specific findings of basophilic stippling and the patient's occupational exposure make lead poisoning more likely in this context. Thalassemia also causes microcytic anemia, but it is associated with target cells and not with basophilic stippling ringed sideroblasts or occupational exposure to toxins like lead.
All right, now that we have covered this question, let's move on to look at the next question.
A 30-year-old woman presents to the emergency department with severe abdominal pain, nausea, and vomiting. She reports that the pain started suddenly 2 days ago and has progressively worsened. She also mentions that her urine has been dark red over the past few days. Her past medical history is significant for similar episodes, and her mother had similar symptoms. Physical examination reveals mild abdominal tenderness with no signs of peritonitis. Laboratory tests show elevated levels of porphobolinogen and D-alanine in her urine. Which of the following is the most likely diagnosis?
All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now.
The correct answer is C, acute intermittent porphyria. Acute intermittent porphyria, AIP, is an autosomal dominant disorder caused by a deficiency of porphobolinogen deaminase, leading to the accumulation of porphobolinogen and DALA. The patient's symptoms of severe abdominal pain, nausea, vomiting, and dark red urine, along with a family history of similar symptoms, are characteristic of AIP. The elevated levels of porphobolinogen and D-alanine in the urine confirm the diagnosis.
All right, let's go ahead and see why the other answer choices are incorrect.
The incorrect choices can be explained as follows. Acute pancreatitis typically presents with severe abdominal pain radiating to the back, elevated amylase and lipase levels, and no specific urine findings. Gallstones usually cause right upper quadrant pain and can be associated with jaundice but do not cause dark red urine or elevated porphobolinogen and D-alanine levels. Chronic hepatitis presents with symptoms such as jaundice, fatigue, and elevated liver enzymes, but it does not cause dark red urine or the acute symptoms described. Peptic ulcer disease often presents with epigastric pain related to meals and may cause gastrointestinal bleeding, but it does not cause dark red urine or elevated porphobolinogen and D-alanine levels.
All right, now that we have covered this question, let's move on to look at the next question.
A 52-year-old man presents to the dermatology clinic with complaints of chronic blistering on his hands and forearms. He reports that the blisters worsen with sun exposure and take a long time to heal, often leaving scars. He also mentions that his urine has appeared dark over the past few months. He denies any significant past medical history but has a history of chronic alcohol use. Physical examination reveals hyperpigmented and thickened skin with multiple healing blisters on sun-exposed areas. Laboratory tests show elevated levels of uroporphyrins in the urine. Which of the following is the most likely diagnosis?
All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now.
The correct answer is C. Porphyria cutanea tarda. Porphyria cutanea tarda PCT is caused by a deficiency of erythroporphyrinogen decarboxylase, leading to increased levels of erythroporphyrins in the urine. The condition is characterized by photosensitivity, blistering skin lesions on sun-exposed areas, and dark or tea-colored urine. The patient's chronic blistering worsened by sun exposure and elevated urinary erythroporphyrins are characteristic of PCT.
All right, let's go ahead and see why the other answer choices are incorrect.
The incorrect choices are a SLE includes photosensitivity but also malar rash, systemic symptoms, and positive ANA not seen here. Dermatitis herpetiformis has pruritic vesicles linked to celiac disease but no dark urine or elevated erythroporphyrins. D. bullous pemphigoid shows tense blisters in elderly patients, not photosensitivity or dark urine. E. epidermolysis bullosa causes skin fragility and blistering but lacks photosensitivity, dark urine, or elevated erythroporphyrins.
All right, guys, that is all I have for today. Be sure to leave a like if you found this video useful, a dislike if you did not find this video useful, and consider subscribing for more content like this in the future. If you would like to check out more review material, be sure to check out my other USMLE/NBME playlists on the channel. If you have any questions, comments, concerns, or suggestions you would like to make, please be sure to write them up and submit them in the comment section below. This is FixerMed signing off. Be sure to have a great day or great night, and as always, good luck studying.